Hello, everybody. My name is Robert Riley, interventional cardiologist at the Crest Hospital in Cincinnati, Ohio. And on behalf of the TCDMD CHIP newsletter, I'd like to welcome you to our latest installment of the CHIP Update series. This is a new series we started for the newsletter where we aim to interview luminaries in the interventional cardiology field that have a special focus on various issues that are pertinent to the CHIP space. And today with me, I have the pleasure of having Dr. Cindy Grines. Dr. Grines is an interventional cardiologist and chief scientific officer at the Northside Hospital Cardiovascular Institute in Atlanta, Georgia, and the current president of SCAI. It is truly an honor to have her with us today. And so welcome, Dr. Grines.
Thank you, Rob. It's delightful to be here.
Absolutely. So as most of our viewers know, Dr. Grines has an extensive experience performing complex procedures in the clinical education sphere, and her investigational work has really helped lay some of the foundational principles by which we currently practice. I think a recent quote illustrates a lot of these principles quite well, and it was in this recent editorial by Dr. Robert Safian from Beaumont in Detroit. And it was in an editorial about a JACC piece on mental skills training in interventional cardiology. And he described a sort of maligned quote from George Bernard Shaw's Man and Superman that says, "Those who can do and those who can't teach." And I think Dr. Safian then quotes, this person clearly never met such individuals such as Spencer King, Don Bain, Bill O'Neill, and Cindy Grines, who are not only extraordinary interventional cardiologists, but also incredibly powerful teachers and role models. And I think her experience in each of these roles will be the focus of our interview today. So Dr. Grines, tell us a little bit about your practice and how it's evolved over the years.
Well, my practice has evolved enormously. Of course, I started out in the academic university hospital setting the way most people do when they go through their training, and I was at the University of Michigan. And I think that was really important for me to strike out in the direction of acute MI, because I was there during the heyday of thrombolytic trials, the TAMI trials, and we had to, we weren't doing primary angioplasty at the time, but those thrombolytic patients were coming into the hospital, and we had to do 60-minute, 90-minute, 120-minute angiograms. And it was just so painful to not only stand there that long, but to watch that patient suffering, waiting for the thrombolytic drug to work. And then after 120 minutes, we could pass a wire and perform rescue angioplasty. And working with Bill O'Neill, we then went on to do a lot of trials in primary angioplasty. And it was quite challenging, of course, because the big money was in the pharmaceutical industry, and a lot of people didn't want to have to get out of bed and do all this extra work. And so it took a long time, actually probably more than a decade, for our work to be recognized. But we were able to do a series of trials, some registries, followed by the very first PAMI trial randomizing patients to TPA versus primary angioplasty. And then we combined our trial with other trials and performed some of the very first meta-analyses done in cardiology. And ultimately, we proved that primary angioplasty was vastly superior. Obviously, it improves patency rates, reduces the risk of serious bleeding, such as intracranial bleeding, shortens length of hospital stay, reduces reocclusion, reinfarction, and ultimately improves mortality. So I'm thrilled that some of our early work was very important in terms of changing the practice of medicine across the globe.
Mm-hmm. That's fantastic. And I mean, I think it's such a unique opportunity for both myself and our listeners and readers to really be able to interact with somebody who has this kind of experience and really see angioplasty from really its early infancy days and now to seeing what it is. And on the heels of that, are there certain types of procedures that you might do now or see performed now that were really considered more taboo sort of when you started your angioplasty practice?
Well, absolutely. Back when we were doing angioplasty, everybody was extremely fearful of any thrombotic lesion. So of course we wouldn't touch a thrombus containing coronary artery. Also, performing stenting in the setting of an acute MI was considered taboo because, again, there was a very high rate of stent thrombosis in the very early trials. In fact, it was almost 20% stent thrombosis. And so when we did our very first stent PAMI trial, where we used a heparin-coated stent compared to balloon angioplasty, that was considered revolutionary. It allowed us, though, to see that these first-generation bulky stents were could be potentially harmful though too, because we had a slight increased risk of no reflow with placement of a stent. And in large part, it seemed to be due to the post-dilation of that lesion with a bulky NC balloon. Oh, and so it kind of led the way to what we do now, which was more direct stenting, the no touch or gentle touch technique with thrombotic or ulcerated or degenerated vein graft lesions.
Mm-hmm. Absolutely. You have such an extensive clinical and investigational history with both cardiogenic shock and acute coronary syndromes. Can you talk a little bit about how you've seen the treatment of ACS, and particularly cardiogenic shock, sort of change over the last decade or so, and in particular how the Sky Shock Initiative has impacted this care both now and moving forward?
Well, I think that with regard to acute coronary syndromes, it has evolved enormously from being watchful waiting, right? You give a thrombolytic drug and then you just watch and wait and see how the patients do. Now we're, taking them directed to the cath lab. Even if you've given a thrombolytic drug at one of the outside hospitals, you're supposed to perform the catheterization within 24 hours because randomized trials have shown that that's beneficial. And the same thing goes for patients with high risk ACS. There are a series of trials looking at cooling them down with antiplatelet agents or antithrombin agents, and ultimately it was shown that really you should be doing these procedures within 24 hours. And so we've moved from that very cautious approach to a much more aggressive approach with all ACS. Now, with regard to cardiogenic shock, it's been harder to, move off the needle. Obviously, Judith Hochman's original shock trial showed that taking those patients to the cath lab, defining the anatomy, fixing what you can fix either with PCI or bypass surgery was beneficial compared to this, best medical care, which may have included a balloon pump. But since then, it's been a little more problematic because it's been quite difficult for randomized trials, particularly in this country. And over in Europe, they've been able to do the shock trial using balloon pumps, showing that there is no particular benefit to balloon pump. And then, of course, culprit shock, which suggests that we should not perform multivessel PCI, at least acutely, in those patients with cardiogenic shock. Now, what we're doing more now in this country is best practices, where we have standardized protocols and systems of care in place, so we can actually follow those systems of care. And what has been shown is that you actually end up treating a lot more patients. There's less bias to withhold care in women and in lower socioeconomic groups because we're following a protocol now. It appears that the survival is better if one follows those protocols, but due to the protocol itself, which suggests that we put in an Impella early prior to reperfusion, that we place a PA catheter, a Swan, to help guide our therapy, or whether it's just an additional experience with all of these teams, it's hard to know. But we do appear to be doing better in the area of cardiogenic shock. Now, Sky has tried to take a forward thinking role of this, and we actually were kind of confused with the fact that the mortality was all over the map. Could range from 30% in some series and up to 80 to 90% in other series. And so we developed this shock classification, A, B, C, D, E, that we found to be very helpful. And several have been able to replicate a gradient of survival based on what shock classifications the patients presented in. And what's important about this is that we can actually look at patients in stage A, those are at risk, or stage B, these are beginning cardiogenic shock. And if you can identify those patients early, hopefully you're going to do something to prevent them from going into cardiogenic shock. And then at the E stage, the extremis stage, it was, those patients might not survive no matter what you do. And so when one designs a randomized trial, perhaps they should consider excluding those patients in extremis.
Yeah, I think for a lot of us who take care of a lot of patients like this, Sky coming up with this document, and then the education, subsequent investigations, and then sort of sister investigations that have come along beside it have really made a big difference in how we care for patients. And I think we're really going to continue to see this evolve over the years. So I think that's been an amazing educational effort by Sky. Speaking of that, let's transition a little bit into your role as president of SCI. Can you tell us a little bit about that role and some of your responsibilities?
Well, I'm proud that I'm the third woman ever to be the president of SCI. SCI's been around since 1970s, and of course it's, very male dominated. We only have about, I think, 4.5% of practicing interventional cardiologists are women. And so it's been, I'm really thrilled to be here, and I'm trying to be more inclusive and to try to make some changes in terms of getting more women involved. But we have a whole committee that does that. It's called WIN, SCI, Women in Innovations. And Roxana Moran was actually the first one who started this, and I inherited it and helped advance it. And currently, Alexander Lansky is at the helm of that organization. And as such, we try to foster women. We try to promote them, get them on the podium, professional development. We also do research by the women or about women patients, and provide education to, a lot of men think that women are no different, but, we're here to tell you that they are very different in terms of their symptoms, in terms of their bleeding complications, the response to various therapies, and even the risk factors for developing disease are quite unique. And so, I think that's been really, really helpful. Another project that I've personally been very interested in is this diversity, particularly with regard to, African Americans who seem to, really have a burden of disease and poor outcomes compared to Caucasians. And so we're doing some, review of the literature and trying to pull together the data to demonstrate that, and actively try to make changes in that regard as well. We're trying to get SCI more in the forefront in terms of doing these kind of video conferences, and we've established several of those. We have our scientific sessions meeting was all virtual this year, and we're also doing this cases where each one of the clinical councils is asking for cases, and then those cases are going to be vetted and presented in a format where there's a panel to discuss them, and individuals who are watching it can write in questions.
Absolutely. And I think we're going to start seeing a lot more of that. And I think people should definitely tune in, because this will be a really great opportunity to go over some complex cases with some real thought leaders in the field. In regards to CHIP, how have you seen sort of SCI's vision evolve for education, investigation, and advocacy in the CHIP space in particular?
Well, with regard to advocacy, we have a huge department now that's called Governmental Relations, and it's spearheaded by a new individual, Curtis Rooney. And Dr. Box is actually the chair of that committee, and they together have made some incredible headway. So we have this PAC where people are donating money, and they're going to Congress and trying to lobby. Right now, they're working on avoiding Medicare from reducing the payments. Every so often it comes up that they're going to cut our salaries by 10 to 20%. And they're lobbying very hard at this point in time to prevent that from happening, because we've already taken a big hit from COVID, right? Many individuals who are RVU based or perhaps fee-for-service based have found dramatic reductions in their salaries. So they're lobbying Congress. They're also working hard to get reimbursement for a variety of these type of, I won't mention any names, but they're working behind the scenes, or at least with Congress, to get reimbursement. They're trying to help push through various orphan type of devices that we might find useful in the interventional space.
Absolutely. I think that's amazingly fantastic. I think we're all really appreciative for all of the efforts put forth by SCI and other organizations to sort of keep us able to take care of patients first. Sort of to finish up a little bit, I'd love to hear your perspective on some of our, younger sort of academic-minded CHIP operators who might want to pursue this sort of academic, innovative path that you have. What kind of advice would you have for them if they looked at a career like yours and said, gosh, I really want to emulate that? What would you tell them at this point in their career?
Well, I think that they really need to start early. At least that's what I did. During my residency, I always was asking about projects. What can I do? What can I write up? Even during my residency, when it wasn't very scientifically oriented, right? It was all about manual labor. I was able to write up a few case reports. I always said yes to anything academic and volunteered a lot. And so during my residency, I actually wrote a grant that allowed me to have a year of funded research. I did the same thing during my fellowship and got 3 years of funding through a VA Career Development Award. And the interesting thing is that I didn't, I was kind of young and naive, and I didn't even realize I had to be a faculty member in order to get this grant. And I wrote it and it was awarded. And so they made me a faculty member at the time that I was at the time I was a fellow, just so the university could get the money, right? But that really puts you ahead, because then you can have some dedicated time to do the research. And if you get a couple of publications under your belt at a very young age, then that's important. It sets you apart from the average person who's going through training. But I should ask you the same question. You've been quite successful. What was your secret?
My secret is taking advice from people wiser and further along the line from me. So I'm really just listening to people like yourself. That's the secret I would put out there for everybody listening. Well, listen, thank you so much for spending time with us today and enlightening us with your experience, Dr. Grines. On behalf of the TCTMB CHIP newsletter, thank you all for joining us, and we look forward to bringing you new content again next month. Thank you.
Thank you.